In the part 4 of diseases of the skin, we are going to study epidermolysis bullosa and pemphigoid. Now, epidermolysis bullosa is a group of inherited bullous disorders characterized by blister formation in response to a mechanical trauma. So, basically, we have three types of epidermolysis bullosa. Now, the etiology, coming to the etiology of epidermolysis bullosa is thought to be due to mutation of any gene. In the first type, it is due to mutation in keratin 5 and 14. In the second type, it is due to the mutation in the gene LAMB3. In the last form, it is due to mutation in the gene COL7A1. Now, there is another variant of epidermolysis bullosa that is known as hemidesmosomal variant. Now, what happens in hemidesmosomal variant? There is blistering produced at the level of hemidesmosomal level. Now, coming to the clinical features of epidermolysis bullosa simplex, it is divided into two forms. One is the generalized form and another is the localized form. Now, the generalized form, it shows an autosomal dominant characteristic. Bullae and vesicles are seen on hand and feet or at the site of friction or trauma. They may be seen on knees, elbow, and nails may oftenly be involved. Now, scarring is not seen in this type. Now, coming to the localized form, it is also known as Weber-Cockayne syndrome. Weber-Cockayne syndrome. Now, in this form, hands and feet are mostly involved and they tend to exhiberate in hot weather conditions. Now, coming to junctional epidermolysis bullosa, its onset occurs at the time of birth. Now, there is absence of scarring or pigmentation in this condition, and death may occur within 3 months. Death may occur within 3 months due to this condition, and bullae develop rapidly, and skin sheets of the skin may shed. Now, coming to the third type, that is dystrophic epidermolysis bullosa. In this, we have two types. One is dominant and one other is recessive. In the dominant type, the onset occurs in infancy. There are blisters on ankles, knees, elbows, feet, and head. Nails are thick and dystrophic. Now, in the recessive type, the onset is also seen at birth, and there is spontaneous formation of bullae, and the sites include feet, buttocks, scapula, elbows, and fingers. Bullae heal by scar or pigmentation. Now, coming to the oral manifestations, this chart represents the oral manifestations of various types of epidermolysis bullosa. You can go through it. Now, this is the histology, as there are many types, so histology differs a bit. So, here we have compiled the histology for you. For the management will be majorly symptomatic and will involve the drainage of the blisters and giving antibiotics to the patient. Now, coming to the next lesion, that is bullous pemphigoid. It is also known as Pemphigus. Now, it is also an autoimmune disease where bullae and vesicles are formed. Now, in this condition, the bullae or vesicle are formed in the subepidermal layer. That is, the epidermis remains intact, and the bullae formation or vesicle formation occurs in the subepidermal layer. Now, these are the cells. These are the basal cells, and this is the connective tissue. Now, in case of a pemphigoid, the defect occurring is here, and the vesicle is formed in this region, that is subepidermal region. Now, to understand the fact, I will represent it diagrammatically. So, if these are the basal cells, these are all the basal cells, these are connected to each other by desmosomes, and the cells above it, these are all connected by desmosomal connections. Now, there are another connections which provide attachment to the basement membrane. These are known as hemidesmosomes. Now, in this condition, the the antibodies are produced against these sites, the hemidesmosomes. So, when these are destroyed, the connections are destroyed. So, a vesicle formation will occur here. So, as you can see, this is the epithelium, this is the basement membrane, and these are the basal cells. So, the vesicle will be formed here, somewhat here. Okay. Now, coming to the clinical features, it is usually seen after 60 years of age, and the skin lesions involve most commonly the limbs, and itching may be seen. There may be vesiculobullous lesions which may be seen. The vesiculo and bulla are relatively thick-walled and may remain intact for some days and then rupture, but do not leave an eroded surface and heal rapidly. They may leave a raw area that will heal rapidly then. These are the oral manifestations regarding bullous pemphigoid. This is the histological diagram. There is a subepidermal bullae. So this is the epidermis and this is the connective tissue. So here the vesicle is formed. This is the subepidermal bullae. The epithelium is normal and vesicle may contain fibrinous, exudate and inflammatory cells. Management is basically systemic steroids. Now, benign mucous membrane pemphigoid. Benign mucous membrane pemphigoid, we will start. It is also known as cicatricial pemphigoid or mucous membrane pemphigoid. Okay, these are the two names for it. Ocular pemphigus is a name which is sometimes used for it. Now, coming to the etiology of benign mucous membrane pemphigoid. Sorry, I skipped the etiology for bullous pemphigoid. You saw the mechanism here. Now we are going to talk about the etiological factors of bullous pemphigoid. Now, what happens in bullous pemphigoid? It is basically an autoimmune disease. Now, where autoantibodies IgG are produced against the hemidesmosomal components. Now, what are the hemidesmosomal components? These are the bullous pemphigoid antigens BP230 and BP180. Now, in BP230 is also named as BPAG1 and this BP180 is also known as BPAG2. Okay. Now what happens is when these autoantibodies are produced against these antigens, there is activation of a component system which attracts inflammatory cells and then degrades the hemidesmosomal protein and leads to the formation of the blister. Now in benign mucous membrane pemphigoid, same thing occurs, but here the target antibodies are associated with BPAG2 and laminin 5. These are the target antigens. Coming to the clinical features, these are seen basically after 50 years of age, most commonly seen in females. The sites involved are oral mucous membrane, conjunctiva and the skin. These are the eye lesions which are seen, and these are the oral mucosal lesions which are seen. Now coming to the histology, it is somewhat same to that of bullous pemphigoid, and the management here we have a topical therapy and a systemic therapy. Now in the topical therapy we give topical steroids, and in the systemic therapy cyclophosphamide is given. So this concludes with the bullous pemphigoid and mucous membrane pemphigoid. Next we are going to discuss in the last part is pemphigus.